Hey everybody, Professor Bob Long here, your anatomy and physiology professor. This lecture is intended for my biology 2402 or human A&P2 courses at Del Mar College. We are covering the heart. We were supposed to have already tested on it, but during spring break this coronavirus outbreak happened and we extended spring break. So I'm doing a series of videos to kind of get you back up to speed before we take our quizzes next week. So anyway, if you're in my class, follow along in your note set. If you're not in my class, then don't follow along in the note set. I hope you learned something from it. Maybe you can glean some information, some understanding. Also, I'm going to try to stay in the frame here of the board, but if I move forward, sometimes it cuts my head off. Just pay attention to the material. Y'all don't want to see me anyway. All right, so what we're going to cover today is, I think it's heart lecture number 3. I forget which number, but it'll be in the title of the video on YouTube. But essentially, this is the heart lecture on the EKG, and we're going to put it together with the cardiac cycle and try to tie several of the last lectures together. We've already done this, but I'm doing it again as a refresher. So now, the EKG gets its name from the word electrocardiogram. A lot of the machinery and a lot of the engineering and a lot of the stuff was figured out by some German scientists and physicians. So cardio is spelled with a K there. Here, we call it the ECG now, and the K in cardio is replaced with the C, so it's called the electrocardiogram as the ECG. You can use EKG or ECG. I'm not going to get into the timing and the numbers of this. I want the concepts and the coordination of the heart functions to go together with this, so that's what I'm really concerned about. So now, if we look at a common ECG trace, what we will see is a series of waves. And again, these are going to be approximations, so for those of you that are super technical people, please don't send me a bunch of messages saying this, that, or the other is wrong. I'm trying to get a fundamental understanding for the very intro level A&P students. We'll get more complex and more detailed over time, okay? Anyway, as this goes on, there'll be a long delay, and then we start the whole process over again, okay? So I didn't draw these exactly the same. These traces aren't perfect, but nonetheless, we have the waves here named the P wave, the Q wave, the R wave, the S wave, and the T wave. And then we get back to the beginning of the next P wave. What we call one cardiac cycle is from the beginning of one P wave to the beginning of the next P wave, okay? As we've noted in the notes, the P wave, and I'm not going to write all this out for you. You can follow in the notes set or work on the worksheets. But the P wave corresponds to two events, one electrical, one physical. The electrical event is the depolarization of the atria. That will result in the atria beginning to contract and squeeze blood into the ventricles. So prior to the P wave, what we would have is all 4 chambers of the heart are relaxed and the AV valves are open. So I can write this out, all 4 chambers relaxed, or we could say they are in diastole, and the AV valves are open, the semilunar valves are closed. I'm going to abbreviate the AV valves as, the atrioventricular valves as AV, the semilunar valves as SL. As you know, the AV valves are the tricuspid and the bicuspid valve. The semilunar valves would be the pulmonary valve and the aortic valve at the base of the 2 great vessels. So, while all 4 chambers are relaxed prior to the P wave, essentially what's happening is blood is returning through the vena cava and through the pulmonary veins into the atria. And as the blood begins filling the atria, it will fall through the ventricles and begin filling the ventricles. During this process, the ventricles get about 70% filled. Then, when we get to the P wave, essentially as the voltage spreads from the SA node, when it depolarizes throughout the atria, my way of seeing it is this. The atria begin contracting and squeezing blood into these valves, topping off the ventricles. So as the atria is squeezed, it's forcing all the blood here, completely filling the ventricles to where they're about 100% full. And I'm talking about the ventricles when I'm talking about filling. When we get to the QRS complex, and shortly thereafter, essentially what's happened is the atria have relaxed, but now the ventricles have contracted. And the way I kind of picture in my simplistic brain is the heart looks something like this, and I have the pulmonary trunk coming up one side with the pulmonary semilunar valves, and the aorta coming out the other side with the aortic valves, and here's the interventricular septum. And essentially, blood is still returning into the atria and always filling the atria, but because the pressure has forced the atrioventricular valves closed, no blood can fall in, and then the ventricles are squeezing blood up towards these two valves and ejecting blood. And essentially, there's a little bit longer time frame here for the ventricles to get that full squeeze and squeeze as much blood out as possible. As they do that and eject blood, when we get to the T wave, so the QRS complex, by the way, corresponds to the depolarization of the ventricles. So now the action potential has spread through the internodal pathway from the AV node, through the bundle of His, the two bundle branches and the Purkinje fibers, and actually hit the ventricles, and the ventricles begin to contract. The atria contract during the P wave, during atrial depolarization. So when I get to the P wave, what I have is atrial depolarization and atrial systole. The AV valves are open, the semilunar valves are still closed. When I get to the QRS complex, essentially what happens is the atria repolarize and are in diastole. But now we have ventricular depolarization or systole. Systole is technically the contraction, but it's happening as it's depolarizing. Now the AV valves are closed and the semilunar valves are open, and blood is ejected out the great vessels. When I get to the T wave corresponds to ventricular repolarization. So P, QRS, and then in the T wave, the ventricles repolarize. They are in diastole. As the ventricles relax, the pressure in the ventricles drops, and the pressure of the blood building up against the AV valves cause them to fall open like trap doors, and blood begins filling the ventricles. And by the time we get to the end of this paused phase, after the T wave to the next P wave, our heart is going to look exactly like where we started. We're going to have all four chambers relaxed, and the ventricles are going to be about 70% full. So you can correspond, you can have the EKG and know what's happening. The P wave is the P wave is atrial depolarization. The QRS complex is ventricular depolarization. It's a larger event because there's more muscle cells and more voltage. And then we have the T wave, which is ventricular repolarization. Turns out that the atria repolarize while the ventricles are depolarizing, so their event is eclipsed here by the much larger event. Some people ask me why these are positive, kind of going up, and these waves are deflecting down. Students always ask. It actually happens to do with how the leads are placed on the body. And when the voltage is running towards the lead and then running away from the lead, at least that's the way it's been explained to me in surgery. But nonetheless, I don't care about that detail. What I want you to know is what's happening here, both electrically and physically. Electrically, during the P wave, the atria are depolarizing. Physically, the atria are beginning systole or contraction. The AV valves are open, the semilunar valves are closed, and we top the ventricles off. And then when we get to the QRS complex, the electrical event is we have the ventricles depolarizing while the atria repolarize. The physical event is the ventricles go into systole. They contract, closing the AV valves, and the semilunar valves are blown open and blood is ejected. When we get to the T wave, the ventricles begin repolarizing. That's the electrical event. The physical event is they go into diastole. And something to note here is We're back in all 4 chambers relaxed. The AV valves open and the semilunar valves close again. The reason the semilunar valves are closed is I don't want blood falling backwards from the great vessels into the ventricles. I never want the backward flow of blood, which is called regurgitation. That would be a bad thing. Once we get to the next P wave, it all starts over again. And you can literally kind of see here the heart sounds happening, which is called auscultation. Auscultation is the process of listening to the heart sounds when they stick the stethoscope on your chest. The sounds, by the way, happen to be called Korotkov sounds. I'm going to write this over here, but the sounds that you hear are referred to as Korotkov sounds, named after a physician who described all of this and figured it out. And the Korotkov sounds are described as a lub and a dup. The lub sound, your mouth opens up, and the dup sound, your mouth slams shut, and you can almost hear that sound. Lub, dup, lub, dup, lub, dup, lub, dup, if you hear a normal heartbeat. And essentially what you're hearing is, well, before we get to the sounds, when we get to the P wave, the atria contract. When we get to QR complex, the atria relax and the ventricles contract, ejecting the blood. When we get to the T wave, the ventricles relax and begin filling, and then we have this long filling time where all 4 chambers are relaxed. And that's what gives you the boom, 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 boom that you hear. Okay? Anyway, one other thing to note is this filling time is just as important as getting the blood out. If I don't put as much blood in, let's say I only put 50% of the blood in. Let's say I shorten this filling time to where I only get 50% full, even with the atria contracting. Then I can only eject 50% of the blood. We're going to get into another lecture called cardiodynamics that's going to get into all of those details. I'm going to try to keep this lecture a little shorter. So anyway, the lub sound, by the way, is the first heart sound that you hear, and it is due to the closure of the AV valves. The AV valves close very kind of gently when the ventricles begin to contract. The second sound, the dup, is the closure of the semilunar valves. When the ventricles relax, they relax rather kind of rapidly, sucking those semilunar valves shut really hard. Lub dup, lub dup, lub dup, lub dup. Anyway, all of that stuff's in your notes, in your note set. Please make sure you review this stuff and be prepared for the quiz. I hope this was helpful. I hope you had as much fun as I did. I hope you learned something. And I'll see you on the flip side for another video in the very near future. Thanks.